Hello everyone, this is Dr. DrBarai. I'm a consultant in MRSA medicine. Over the next few minutes, we are going to talk about the pitfalls of LVOT VTI. We use LVOT VTI all the time in case of these critically unwell patients such as shock, heart failure, pulmonary embolism. LVOT VTI is such an useful tool. It helps us to decide what is the best treatment modality for a patient. Having said that, LVOT VTI has got some pitfalls or some limitations that we need to be aware of so that we can make the best use of it. So without further delay, let's dive into it for further details. If you have not done already, please subscribe to the channel and share this to others. Thank you very much. So what are the learning objectives? What are you going to learn over the next half an hour or so? Now you may be surprised why this doctor is doing the echocardiography on the right side of the patient. Well, this gentleman has got a dextrocardia. So he is doing the echocardiography on the right side of the patient. That is absolutely fine. So the first thing that we are going to learn is that we'll understand the common sources of error of the LVOT VTI. We'll recognize the clinical context where LVOT VTI is less reliable, so we need to think about some alternatives in those cases. We'll be able to apply the practical checklist to ensure the high quality of care of the patients and also accurate interpretation of the LVOT VTI results. We'll know how to troubleshoot the different challenging situations, and we'll understand when to use the alternative methods. The most important objective of this presentation is to be aware of the limitations or the pitfalls of LVOT VTI so that we can address those issues and make the best use of this technique. So what is LVOT VTI? If you have watched my previous videos on this topic, I'm sure you are aware of it, and I'm sure that you are using LVOT VTI in your clinical practice already. So let's recap. Let's summarize the LVOT VTI. So this is the parasternal long axis view, and this is the right ventricular outflow tract, interventricular septum. This is the left ventricular outflow tract, and the whole area, that is the left ventricle. This is the mitral valve, the anterior leaflet and the posterior leaflet, and this is the left atrium. The aortic valve is here, and this is the ascending aorta. So blood is coming from the lungs to the left atrium. Through the mitral valve, it is going to the left ventricle. Through the left ventricular outflow tract, it is going to the ascending aorta and rest of the body during each of the cardiac cycle or left ventricular contraction. Now our area of interest is what happens to the blood here. So every red blood cells, all the blood that is going to your brain, to your kidneys, to the rest of the body, that actually is coming from here. So this area, we call this LVOT or left ventricular outflow tract. If you carefully look at it, it looks like a cylinder. Of course, this is a two-dimensional view. So in real life, this is in three-dimensional view, this looks like a cylinder, just like this. So like a cylinder, it has got a diameter, an area, and a height of the cylinder. By using the Doppler technique, we can measure exactly what height of the cylinder is. In other words, how far a specific red cell is traveling during each cardiac cycle. As you can see that every time the left ventricle is contracting, this cylinder of blood which is sitting in the left ventricular outflow tract is going to the ascending aorta and the rest of the body. As I mentioned, by using the Doppler technique, we can measure the height of the cylinder, or in other words, the distance of the that the RBC is traveling or the blood is traveling to. So this is the cylinder that we are talking about. As you can see that in the cylinder, there is the area of the cylinder and the height of the cylinder. And if we use the formula that the volume of the cylinder is equal to the area multiplied with the height, then we can easily get the stroke volume. That means the amount of blood that is pumped from the left ventricle during each cardiac cycle. We can easily measure the diameter of the left ventricular outflow tract, which is leading edge to leading edge distance. If we divide the diameter by 2, we get the radius, and radius square multiplied by pi gives us the surface area of the cylinder, and the volume is the area multiplied by the height of the cylinder, and this height actually is the VTI, the velocity time integral. This is the apical 4-chamber view. The left ventricle is here, the left atrium is here, and this is the mitral valve. This is the right ventricle with trabeculae, and this is the tricuspid valve here, and this is the right atrium. If we tilt the probe a little bit, then we will get the apical 5-chamber view where the aortic valve will be visualized somewhere here. And if we apply the pulse wave Doppler and apply the signal of the Doppler just about 3 to 5 millimeter below the aortic valve, so the aortic valve is here, then we will get these waveforms. And we can actually measure the area under the wave forms by using the computer tracing technique, and that will give us the value, which is the VTI. As you can see in this particular patient, the LVOT VTI is 18.3 centimeter. What it necessarily means is that every time the left ventricle is contracting, the blood is flowing through 18.3 centimeter. That is the height of the cylinder. Now, why LVOT VTI matters, and why would you like to use this technique for your patients, and why would you bother about the pitfalls? So every time we look at the patient, we need to know exactly how much blood the heart is pumping right now as we speak. And the best way to do that is we can do that through these LVOT VTI measurements. This is a very useful technique. It is non-invasive. It gives us a real time window of the cardiac output. It is a perceived simplicity. It's a very simple technique. And if we know the stroke volume through the VTI, we can multiply by heart rate, and that will get the cardiac output. So why this VTI matters? We have talked about that formula that the VTI is the area under the velocity timing curve, and the stroke volume is the velocity left ventricular outflow tract area multiplied by VTI. And cardiac output is the stroke volume multiplied by the heart rate. Now, the clinical areas where this LVOT VTI can be useful is, of course, in the emergency department, that we use this technique all the time for shock patient, heart failure patient, pulmonary embolism patients. In intensive care unit and in the operation theater, this technique is also used. If we find that a patient is hypotensive and we want to determine whether they are fluid responsive or not, we can use this LVOT VTI. For example, if we do the passive leg raise and if we find that there is more than 15% elevation of the LVOT VTI, we know this person is fluid responsive. We can also use this LVOT VTI for therapy monitoring. What it means? It means we can give some treatment and then we check the LVOT VTI before and after, and we see if there is any change or improvement of the LVOT VTI. For example, we can give noradrenaline in a patient of shock, check the LVOT VTI, and if we find that there is a 15% increase, that is great. So this person is responding to that particular treatment. Now, the main topic of today is the pitfalls, limitations, the errors of LVOT VTI. As you can see, this is like a minefield, an iceberg. When we talk about the LVOT VTI, we are talking about the simple formula that the stroke volume is equal to the area multiplied by the VTI. However, we are looking at the tip of the iceberg. There is a minefield of hidden errors. For example, there can be acquisition errors, there may be geometric and assumption errors, there may be patient and context limitations, and of course there may be interpretation and serial measurement errors. Over the next few minutes, we will discuss each of them, and also we are going to tell you how we can address these issues, how we can make it better, how we can make the best use of this useful technique. The first error that we come across is the acquisition error. What does it mean? So let's get into the images and clips so that we can understand this better. As you can see, this is the apical 5-chamber view. We have got the left ventricle here, the left ventricle outflow tract is here, and this is the aortic valve. If we apply the pulse wave Doppler signal in line with the direction of blood flow, that is exactly what is happening here, we get some beautiful waveforms and we can get the measurement of the LVOT VTI quite easily. Now, the main important area here is that the angle of the pulse wave Doppler signal and the direction of flow of blood, they should be less than 20 degrees. If it is more than 20 degrees, then we get wrong results. For example, here, as you can see, this is the same patient or similar type of patient. We have got the left ventricular outflow tract here, and when the Doppler is applied, the angle of the flow of blood is here in this direction, and the Doppler signal is this direction. This is more than 20 degrees, which means that there may be some error. there may be some wrong results. The another error that we find or come across quite often is the sample volume placement and waveform quality. What does it mean? So we have shown you in previous images that the Doppler, pulse wave Doppler sample is applied about 3 to 5 millimeter below the aortic valve. Sometimes it can be quite difficult to detect where exactly we are putting this. So what we can do that is that we can freeze the image, we can zoom in, we can trace the envelope and verify consistent bits. In case of the sample volume placement though, this is a little tricky. So let me show you what happens here. So this is the patient with the left ventricular outflow tract here, apical 5-chamber view. This is the aortic valve. So normally we should apply the pulse wave signal here about 3 to 5 millimeter below the aortic valve. That is exactly what we are doing here, and we have got a good reading about 18.3 centimeter of LVOT VTI, which is pretty normal. By the way, the normal LVOT VTI is 18 to 22 centimeter. Now what happens in the same patient if we apply the signal about 10-12 millimeter below the aortic valve? So the aortic valve is here and the signal is well away from the aortic valve. So we are getting a reading of about 13 centimeter. On the other hand, if we apply the signal just over the aortic valve, we are getting this reading, which is about 19.5 centimeter. So you can see that we can apply the signal in a correct place where we can get the correct LVOT VTI result. But if we use the probe too far or too close, then we will get some wrong results, either too low or too high results. I hope you could understand. By the way, if you have not subscribed to the channel, please subscribe to the channel and share it with others. And if you have any questions or comments, please write in the comment section below. Now there is maybe some geometric assumption errors. For example, if the LVOT diameter measurement is wrong. As we have discussed earlier, that the formula to measure the LVOT area is pi multiplied by radius square. So if there is a little bit of error in the measurement of the radius, we will get square of that error. The error is multiplied several times, so there is a large error. Ideally, we should use the mid systole of the left ventricle. We'll zoom in, we'll do the multiple measurements, and we can average. And the measurement is leading edge to leading edge. So this is the parasternal long axis view. Once again, that is the left ventricular outflow tract. From leading edge to leading edge, during the mid systole, we can do the measurement. The trick here is that most people have got this diameter of 2 centimeter. So the area, the formula for the area of the left ventricular outflow tract is pi multiplied by rs square. R is the radius. So if we measure the diameter and divide it by 2, we get the radius. Now let's show you some real life patients. Assume that the measurement here is 1.8 centimeter. If we use this number in this formula, then we get the area of 2.54 square centimeter. On the other hand, if we measure the diameter of 2.2 centimeter and apply this in this formula, we are getting the area of 3.8 square centimeter. Let's assume that the VTI in this patient is 20 centimeter. So in this case, if we measure this way, it will be 2.54 multiplied by 20, which is 58 ml. That is the stroke volume. And in this case, it will be 3.8 multiplied by 2, which is 76 ml. So there is a huge difference. Even if there is a small little bit of difference in the diameter, we are getting the stroke volume massive difference. So we need to be very careful that we measure the LVOT VTI carefully at least 3 times and then to the average. That will give us a relatively better idea of the actual stroke volume and cardiac output of a patient. Let's talk about the geometric errors or assumption of circular LVOT and constant area. What does it mean? As we have shown you some animations and clips that we are assuming the left ventricular outflow tract is like a cylinder. But in reality, some people may have conical type of left ventricular outflow tract. If the interventricular septum is very thick, like in case of the hypertrophic obstructive cardiomyopathy, they can have a different shape of the LVOT. Many people have got the left ventricular outflow tract as a sigmoid shaped, and that will give you a different challenge as well. So keep in mind that the left ventricular outflow tract is not always cylindrical. So we need to look at the parasternal long axis view and identify what the shape of the left ventricular outflow tract is, and then we need to do the VTI and use the VTI in context of the patient. Let me show you some examples. So in this patient who has got the left ventricular outflow tract, it looks like pretty good, it's cylindrical. However, if you look at here, it's not very good picture, and also the left ventricular outflow tract is like a conical shape. In this patient, however, the interventricular diameter is very thick, and also there is a bit of sigmoid shape pattern in the interventricular septum. So it's not a cylindrical shape either. And of course, this one has got pretty good going sigmoid shaped interventricular septum. The reason I am showing you all these 4 different images is to understand that although we are talking about the left ventricular outflow tract LVOT as cylinder, it may not be the case in your patient. So always look at the parasternal long axis view, look at the shape of the left ventricular outflow tract, and then you do the VTI, and then you do the calculations that what may be the cardiac output or stroke volume. Let's talk about some patient and context limitations. I'm sure you find this challenge quite often. The patient may come with atrial fibrillation, ventricular ectopics. The main challenge here is that there may be bit-to-bit variability of the VTI. So how to address this challenge? The way I address this challenge is that I do 10 measurements. I know it takes a bit of a time, but once I do the 10 measurement, I can do the average, and that gives me a more realistic VTI result rather than relying on only one result. So once again, let's show you some examples. So this patient has got atrial fibrillation quite fast. Here also there is atrial fibrillation and there is this pacemaker. This person has got a very big left atrium and right atrium, and of course they have got atrial fibrillation as well. Now the biggest challenge, as we have mentioned, is that there may be bit-to-bit variability. So some is very small, some is very long, and sometimes in case of those people who have got very fast ventricular response, this VTI can be really difficult to measure because they come very quickly and their shape can be all over the place. So my technique is I measure the VTI at least 10 times and then I average it to get some more realistic result. Another contextual limitation is that valvular disease. I'm sure you will come across many patients who have got valvular disease like aortic stenosis, left ventricular outflow tract obstruction like hypertrophic obstructive cardiomyopathy, maybe prosthetic heart valves, and that can make a big challenge in get a more realistic LVOT VTI. So how to address this? First of all, we need to recognize when LVOT VTI is not appropriate and consider the alternative measures. So let me give you some quick examples here. So this is the same patient. As you can see that there are multiple valvular problems. So first of all, there is some bit of dilated cardiomyopathy and there is a big left atrium and right atrium. There is mitral regurgitation, tricuspid regurgitation, and also there is some aortic regurgitation in this patient. And when we tried to measure the LVOT VTI, it was a big challenge because of these different valvular measurements. So I felt that VTI may not be the best option in this patient. We may have to consider some alternatives. And this is another patient with severe aortic stenosis, and that make a huge challenge as well to get the appropriate LVOT VTI measurement. Another limitation is the poor acoustic windows. For example, in case of the ventilated patients, if we don't get a very good view during the echocardiography, it can be a very big challenge in interpretation of the images, clips, and the measurements. Obesity is a big challenge. Chronic obstructive lung disease is a big challenge. Patient who is intubated with high PEEP, prone positioning, these are big challenges. The one way we can address the challenge is that instead of transthoracic echocardiography, we can do transesophageal echocardiography or other alternative measures like the carotid VTI. Of course, we need to talk about the serial measurement errors or variability and true change. We mentioned this topic that we can measure the LVOT VTI. For example, in atrial fibrillation, we can do it 10 times. Now, when we talk about serial measurement, that is a little bit different. For example, in a patient who is in shock, we can measure the LVOT VTI. We give some treatment, for example, some IV fluid or some noradrenaline, and 15-20 minutes later, we can measure the LVOT VTI again. If we find that there is more than 15% improvement, that means this person is responding to the treatment. However, if this change is less than 15%, probably we need to think about something else, alternative cause or alternative treatment. We need to also consider the interpretation errors. As we have mentioned, that the assumption is that LVOT VTI area is fixed, constant, which is not always the case. Some people may have hypertrophic obstructive cardiomyopathy. Somebody may have the valvular repair, or there may be some pathological change. In those cases, the LVOT area can change, and so we need to measure it appropriately at least 3 times and do the average. These days we get artificial intelligence in many of the new ultrasound machines, and they can do the VTI. The old results, old papers, old research show that there may be some disagreements between the clinician and the AI in automated measurements of the VTI. However, the recent research papers show that there is a very good agreement between the AI and the expert clinicians. As you can see, that the correlation between the clinician and the automated VTI is pretty good. Now let's talk about the proposed checklist, how to address these pitfalls or the errors of the VTI. The proposed step-by-step approach is that first of all, we get a very good apical 5-chamber view. Then we get the LVOT diameter by the parasternal long axis view during the mid-systole, average 3 cycles. We apply the Doppler sample about 5 mm below the aortic valve, and keep in mind that the beam alignment should be less than 20 degrees. We freeze the Doppler, zoom, we trace the envelope carefully for 3 to 5 bits average. We document the heart rate, we view window, quality and settings, and of course we need to interpret the results in the context of the patient, the context of the clinical, the rhythm, the valvular disease, the previous surgeries, windows quality. If there are suboptimal views, we need to document that the measurement of limited reliability and consider the alternatives. So this is my approach. We have got a 7-step approach. So first of all, we need to get good views such as parasternal long axis view for the diameter and apical 5-chamber view for the Doppler. We need to measure the diameter in the parasternal long axis view. We need to zoom in, measure in mid-systole and average 3 cycles at least. Then we place the sample volume. We position the Doppler gate about 5 mm just below the aortic valve. We align the beam, ensure that the Doppler angle is less than 20 degrees of the flow of the LVOT. We trace the waveform. We freeze, zoom, carefully trace the modal velocity envelope, average 3 to 5 bits. In case of AF, however, it can be 10 bits. We need to document very carefully. We need to document the heart rate, the views that we are taking, quality of the views, and of course any limitations. And then we interpret. We consider the result in full clinical context, such as the load, rhythm, and the valve disease. So that's the checklist that we can apply to make the best use of the LVOT VTI, considering we are aware of the limitations or the pitfalls. So from measurement to mastery, the 4 key principles that we need to consider. First of all, embrace the power and respect the peril. So LVOT VTI is a potent tool, but its accuracy is entirely dependent on the operator techniques and the clinical awareness. and critical awareness. Master the big 4 pitfalls. We talked about those pitfalls, and also we talked about how to address them. Make sure that the checklist is a ritual. So every time you apply the LVOT VTI, use the checklist from previous slide. There are seven steps. Use those step-by-step approach and report with candor and document what your findings are, what may be the limitations, so that a clarity can be maintained. So we talked about some alternatives if we cannot apply the LVOT VTI appropriately. So let's go through the alternative. So far we talked about this route, which is LVOT VTI. Now let's go through this route, which is the alternative measures. One of the technique that we frequently use is the inferior vena cava collapsibility or distensibility. Now this is a very simple technique that we can use. The biggest challenge is to get a good view. Again, we may have to do the serial measurements to get a good reliable result. Another technique that we use often is the pulse pressure and the stroke volume variations. We mentioned about this briefly, that when we do not get good views in case of transthoracic echocardiography, we may consider transesophageal echocardiography. For example, in obese patient, postoperative patient, patient who is intubated with high PEEP, prone positioning of the patients. Because we need very good quality pictures and the clips to apply the LVOT VTI measurements. The surrogate for the LVOT VTI is a carotid VTI. However, it has got its own errors and pros and cons as well. So these are the alternatives. So in summary, we talked about the various limitations or errors of the LVOT VTI, and also we talked about how to address those issues. I would suggest go through those 7 steps, and then we will get a very good reliable application of the LVOT VTI. So LVOT VTI is a very powerful technique. However, it has got some limitations. There may be some limitations in acquisition, geometry, patient, context, and interpretation. Use those 7 steps of the checklist and recognize when the data is unreliable. Consider the alternatives. It's very important that we document the method, we document the errors, the quality, and this will make sure that the result of the LVOT VTI can be interpreted appropriately. We have got a lot of research in the topic of LVOT VTI, and there are the few which are listed here. You can go through them, and as I have mentioned, if you have not done already, please subscribe to the channel, and if you have any questions, please write in the comment section below, and I'll be very happy to answer your questions. Thank you very much for taking your time. It was a great privilege talking to you, and I will see you again. Thank you very much. Bye for now.
Hope you understood the pitfalls of LVOT VTI. See you soon with some more awesome videos. Bye for now. And I forgot to tell you that please subscribe to the channel and press on the bell notification button. Cheers!